Familiarity with benign and malignant lesions of the head and neck is essential to the physician, who must distinguish life-threatening masses from those of little consequence, choose appropriate therapy, and avoid injudicious surgery. The most common neck mass is a reactive lymph node. These masses are most often secondary to bacterial or viral infections of the ear, nose, paranasal sinuses, teeth, tonsils, or skin and soft tissues of the head and neck. Masses in children are commonly benign. In adults, neck masses are more likely to be malignant. The typical workup for acquired lesions consists of a detailed history, especially family history of malignancy, past malignancy in the patient, risk factors associated with malignancy, such as smoking and alcohol consumption, as well as exposure to radiation, certain fumes, sawdust, or other potential carcinogens. Additional information needed to complete this history should include past or current upper respiratory infections, sinusitis or tonsillitis, otitis or conjunctivitis, and dental problems. The physical examination should include careful inspection and palpation of the scalp, eyes, ears, nose, and mouth, including the teeth and tonsils, hypopharynx, and nasopharynx for signs of infection, ulceration, or unsuspected abnormalities. Additional workup may include laboratory blood work, such as complete blood count and differential, tuberculin test, heterophil titer, monospot test, thyroid function tests or thyroid scan, serologic tests for syphilis, viral titers, especially for Epstein-Barr, which is associated with nasopharyngeal carcinoma and Burkitt's lymphoma. Radiologic workup may include soft tissue radiographs of the neck, zero radiograms, barium swallow, complete gastrointestinal series, or scanning procedures such as computed tomography, CT, magnetic resonance imaging, MRI, bone scan, or other radioisotope scans. Endoscopic evaluation is indicated to search for the tumor if a primary neoplasm is suspected. Endoscopic biopsy and radiologic study should precede any incision in the neck. The course of treatment depends on the findings during the initial workup. Antibiotic treatment would be administered if a bacterial infection is suspected. Antituberculosis drugs may be administered if the TB test is positive. Consultation with specialists in other fields, such as dentistry if the teeth seem to be the source of the problem, or a dermatologic consultation if scabies or other dermatologic conditions are noted, may be helpful in treating the patient. When a mass does not shrink significantly or disappear within a reasonable time, usually 6 weeks, then surgical treatment or biopsy may be indicated. If cervical adenopathy persists in the presence of enlarged or cryptic tonsils, it is believed by many to be an indication for tonsillectomy. Equivocal or abnormal dental findings should lead to dental treatment. Excisional biopsy or needle biopsy after a complete evaluation for malignancy is indicated if there is persistent cervical adenopathy and the source is not found. Neck biopsy is the last step in a proper workup. Fine needle aspiration can be used to diagnose carcinoma, but it is usually inadequate to define lymphoma. A patient presenting with fever and a painful, fluctuant neck mass probably has an abscess. The source of infection should be identified and drainage should be carried out. Because of danger to the carotid artery, airway, and cranial nerves, deep neck abscesses should be treated only by those knowledgeable in the anatomy and standard surgical technique for the area. Patients should be treated on an emergency basis. Bates-Soltz abscess is a neck abscess that arises from infection in the middle ear or mastoid. Ludwig's angina is an abscess that occupies the sublingual space. It generally arises from a dental source. It can cause death from airway obstruction and frequently requires tracheotomy. Parapharyngeal space abscesses arise from the posterior teeth or tonsils and can affect the carotid sheath structures and multiple cranial nerves. They can cause mediastinitis and carotid blowout, i.e., erosion of the artery wall leading to massive hemorrhage. Retropharyngeal abscesses arise from infected retropharyngeal nodes or extension from other spaces. They can lead to airway obstruction or mediastinitis. Paratonsillar abscesses, quinsy, arise as a complication of acute tonsillitis. They present with ipsilateral palatal edema, contralateral deviation of the uvula, hot potato voice, trismus, and dysphagia. The patient may only have a low-grade fever or be afebrile. These abscesses are most common in the parapharyngeal space, and they require urgent and aggressive medical treatment. Parenchymal cysts consist of two types, Thymic cysts and Parathyroid cysts. Thymic cysts arise from the third pharyngeal pouch and migrate caudally and medially to descend into the superior mediastinum. During this descent, an attachment may remain in the neck. Thymic tissues may present in the neck as separate nodules of mature thymus or may occur in association with ciliated or columnar epithelial remnants of the pharyngeal pouch. They may occur anywhere on a line from the mandibular angle to the suprasternal notch. Approximately 95% of thymic cysts are unilateral, and 90% of thymic ectopias are cystic. They are generally found in children, with a male predominance of occurrence. They may be unilocular or multilocular. Loculated cysts generally contain amber or brown fluid, which may be clear or turbid. Cysts are often asymptomatic, but may be painful if they are infected or if they grow suddenly. Midline cysts may cause dysphagia. Both benign and malignant hyperplasia have been reported in these cysts. Branchial cleft cysts seldom extend inferiorly to the clavicle and often present with signs of acute inflammation. Cystic hygromas are lateral, spongy, and more diffuse, and are generally seen in infants. Surgery is the treatment of choice for these types of cysts. Parathyroid cysts. These unusual cysts generally present in adults aged 30 to 50 years as solitary masses at either inferior pole of the thyroid gland. Tracheal deviation is usual and causes a variable degree of respiratory obstruction. Hoarseness may occur because of pressure on the recurrent laryngeal nerve. Treatment for these cysts is generally surgical excision. The thyroid gland originates at the foramen cecum and descends centrally to the thyroid and cricoid cartilages. The thyroglossal duct may pass in front of, through, or behind the hyoid bone. It is generally obliterated but may persist. Elements of thyroidal primordium may remain at any site in its passage. These elements may give rise not only to cysts and fistulas, but also to accessory thyroid tissue and neoplasms. Most cystic remnants occur in the midline around the hyoid bone. Solid tumors of thyroglossal duct origin occur almost exclusively within the tongue and above the hyoid bone. Thyroid rests. Typical thyroid rests may be lingual or may occur in the neck. Endotracheal ectopias may also occur. Palpation of the normal position of the thyroid often reveals easily palpable tracheal rings in patients with these rests. Treatment is indicated by the degree of obstruction present and by the presence of other thyroid tissue. A thyroid scan should be performed before removal of lesions suspected of being thyroid rests to ensure that there is functional thyroid tissue in the usual location. Between 70 and 80% of patients have no other functional thyroid. These occur in the midline unless previous surgery has produced distortion. Approximately 20% are suprahyoid, 15% occur at the hyoid, and 65% are infrahyoid. Fistulas are almost always the result of infection with spontaneous or surgical drainage. Fistulas can drain internally, externally, or both, complete fistulas. Thyroglossal duct cysts present by age 10 in 50% of cases. There is no sexual predominance, but there is a racial predominance. The cysts occur most often in Caucasians. The cysts usually measure 2 to 4 centimeters in diameter and gradually increase in size, although the size may fluctuate. They rise and fall with the larynx during swallowing. Treatment of these cysts is generally total surgical excision, cyst trunk procedure, including the cyst and sinus to the base of the tongue, the whole fistula, if one is present, and the middle third of the hyoid bone. Cutaneous branchiogenic cysts are rare asymptomatic nodules that are noted soon after birth and gradually increase in size. They are located in the suprasternal notch, and treatment is by local surgical excision. Teratomas are growths that consist of multiple tissues that are foreign to the part of the body in which they arise. There are 3 types of teratomas: epidermoid cysts, dermoid cysts, and teratoid cysts. Epidermoid cyst. The epidermoid cyst is the most common type. It is lined by squamous epithelium and has no adnexa. Dermoid cyst. The dermoid cyst is an epithelium-lined cavity containing skin appendages, that is, hair, glandular tissue, and follicles. Territoid cyst. The teratoid cyst is lined with simple stratified squamous epithelium or respiratory epithelium and contains cheesy keratinous material. They are rare in the head and neck. Cervical teratomas. These are most common at birth, and appearance after the age of 1 is rare. These lesions are usually 5 to 12 centimeters in their long axis and are semicystic, although they may be solid. They are usually unilateral. Infants with cervical dermoids usually have stridor, apnea, or cyanosis because of tracheal compression or deviation. Dysphagia may also be present. Some infants are asymptomatic at birth, but become symptomatic within weeks or months. Associated anomalies of this tumor include an increased incidence of material hydramnios, but affected infants show no increase in associated anomalies. Treatment consists of mandatory early excision in infants. Hemangiomas are the most common tumor of the head and neck in children. Girls are more often affected than boys, and the lesions are usually solitary. There are 5 types of hemangiomas: capillary hemangiomas, cavernous hemangiomas, arteriovenous hemangiomas, invasive hemangiomas, and subglottic hemangiomas. Capillary hemangiomas such as nevus flammeus, port wine stain, and strawberry nevus are characteristically found in the dermis. They rarely appear in adults. They have an early period of evolution after which they regress. They may develop suddenly and grow quite large. Cavernous hemangiomas are more permanent. Spontaneous regression is more likely for hemangiomas present at birth than in those appearing later. Arteriovenous hemangiomas occur almost exclusively in adults and have a predilection for the lips and perioral skin. Invasive hemangiomas occur in the deep subcutaneous tissues, deep facial layers, and muscles. These hemangiomas present as neck masses, predominantly in children. They tend to recur long after excision, but do not metastasize. The masseter and trapezius are the muscles most commonly involved in the head and neck. Intramuscular hemangiomas most commonly present in young adults as palpable, mobile, non-compressible masses. They are generally present with thrills, pulsations, or bruits, and pain secondary to compression of other structures is usually present. Subglottic hemangiomas are usually capillary in type. Owing to their location, they often present at birth or soon thereafter with stridor, and usually with cutaneous involvement as well. These type are generally not treated initially. When patients reach school age, cosmetically deforming lesions may be excised. Steroids may be used to slow the progression of the growth phase if necessary. Tunable dye and copper vapor lasers have shown promise in the treatment of cutaneous lesions. Subglottic lesions may require tracheotomy, steroids, and in some cases, laser excision. Surgery may be needed for extensive lesions. Radiation therapy has been used to suppress tumor growth. However, radiation alone will not affect a cure, and its use in these lesions is controversial. When a mass does not shrink significantly or disappear within a reasonable time, usually 6 weeks, then surgical treatment or biopsy may be indicated. If cervical adenopathy persists in the presence of enlarged or cryptic tonsils, it is believed by many to be an indication for tonsillectomy. Equivocal or abnormal dental findings should lead to dental treatment. Excisional biopsy or needle biopsy after a complete evaluation for malignancy would be indicated if there is persistent cervical adenopathy and the source is not found. Neck biopsy is the last step in a proper workup. Fine needle aspiration can be used to diagnose carcinoma, but it is usually inadequate to define lymphoma. Cystic hygromas are found predominantly in the neck and are usually noted at birth or soon thereafter. They are more common in the posterior triangle and may reach up into the cheek or parotid region and down into the mediastinum or axilla. Large masses extend past the sternocleidomastoid muscle into the anterior compartment and may cross the midline. They may involve the floor of the mouth and the base of the tongue. Significant signs and symptoms may include difficulty in nursing, facial or neck distortion, respiratory distress, brachial plexus compression with pain or hyperesthesia, or a sudden increase in size secondary to spontaneous hemorrhage, which can be fatal. There is no predilection for either sex or for either side of the body. The hygroma can be progressive, static, or regressive. Small lesions are unilocular and firm. Large tumors are loculated, shiftable, and compressible. The hygromas generally transilluminate. The cyst walls are usually tense, and because of loculi tend to communicate, rupture of one locule can cause them all to partially collapse. Surgery is the mainstay of treatment. Oral and perioral lymphangiomas are relatively common lesions that are usually found at birth or soon thereafter. They behave very much like cystic hygromas. When a mass does not shrink significantly or disappear within a reasonable time, usually 6 weeks, then surgical treatment or biopsy may be indicated. If cervical adenopathy persists in the presence of enlarged or cryptic tonsils, it is believed by many to be an indication for tonsillectomy. Equivocal or abnormal dental findings should lead to dental treatment. Excisional biopsy or needle biopsy after a complete evaluation for malignancy would be indicated if there is persistent cervical adenopathy and the source is not found. Neck biopsy is the last step in a proper workup. Fine needle aspiration can be used to diagnose carcinoma, but it is usually inadequate to define lymphoma. In the 4th week of gestation, 5 ridges appear on the ventrolateral surface of the embryonic head with a groove between each. These ridges and grooves form the branchial arches and clefts, respectively. The pharyngeal pouches develop internally at the same level as the external grooves. There are 4 types. A sinus or incomplete fistula has either an internal or an external opening. A complete fistula has both an internal and an external opening. A cyst has neither an internal nor an external opening. A combination of any of the preceding types can occur. Branchial cleft anomalies are generally located along the anterior border of the sternocleidomastoid muscle or deep to it. These anomalies can occur anywhere between the external auditory canal and the clavicle. First branchial cleft anomalies. They are always superior to the hyoid bone. If a fistula is present, it courses superiorly to end near the external auditory canal. The cyst and tract may lie in the parotid gland with a variable relationship to the facial nerve. Third branchial cleft anomalies. Third cleft anomalies are rare. The external opening occurs in the same position as in a second cleft fistula. The tract ascends along the carotid sheath posterior to the internal carotid artery, over the hypoglossal nerve, under the glossopharyngeal nerve, and over the vagus nerve to open in the piriform sinus. Second branchial cleft anomalies. Second branchial cleft anomalies are the most common type. An external opening, when present, is about 2/3 of the way down the sternocleidomastoid anteriorly. The fistula, if present, ascends with the carotid sheath and crosses over the hypoglossal and glossopharyngeal nerves and between the external and internal carotid arteries to end at the tonsillar fossa. Fourth branchial cleft anomalies. Fourth branchial cleft anomalies have never been seen in their entirety. Theoretically, they would have an external opening anterior to the sternocleidomastoid muscle in the lower neck. They would descend along the carotid sheath into the chest, passing under the subclavian artery on the right and the aortic arch on the left, ascend into the neck to cross the hypoglossal nerve, then descend to open into the esophagus. Branchial cleft cysts are generally smooth, round, and non-tender masses. Increases in size during upper respiratory infections are not uncommon. An infected branchial cleft cyst may abscess or rupture spontaneously to form a sinus. The size and location of a branchial cleft anomaly determines the symptoms. Large cysts may cause dysphonia, stridor, and dyspnea, and small cysts are often not discovered until adulthood because of their slow rate of growth and minor symptoms. Definitive treatment consists of complete excision without damage to the surrounding vital structures. Antibiotics are given if the lesion is infected. Incision and drainage are avoided if possible because they make subsequent excision more difficult. Encephaloceles are congenital brain herniations, which may be confused with nasal dermoids or polyps. Meningitis or cerebrospinal fluid leaks are not uncommon, particularly with manipulation. They are usually discovered early in life. Approximately 75% are occipital, 15% are sincipital, and 10% enter the nose or nasopharynx. These lesions may or may not communicate centrally. Communicating lesions increase in size and tension when the infant cries. Non-communicating ones generally do not. Treatment should include total removal. The lesions do not need to be treated as emergencies if there is no imminent threat of meningitis. Leukoplakia and keratosis are white lesions that occur on the mucosa of the mouth, pharynx, or larynx. Erythroplakia is a similar red patch. etiology of these lesions is associated with repeated trauma. There is little connection between the clinical appearance of the lesions and their histology. Erythroplakia is somewhat more likely to be carcinoma. Biopsy to rule out squamous cell carcinoma should be performed in high-risk patients, smokers and drinkers, and/or if the lesion persists after the removal of an irritative focus. Squamous papillomas of the oral cavity usually occur singly but may be multiple. They are common on the palate and fossil arches. They are usually pedunculated and cauliflower-like in appearance. Recurrence is rare after excision. Squamous papillomas of the nasal cavity are warts that are similar in appearance and behavior to cutaneous warts elsewhere on the body. Cylindrical and fungiform papillomas are other forms of benign nasal papillomas. Inverted papillomas are lesions that typically arise from the lateral nasal wall and can invade the sinuses and orbits. Grossly, they appear bulky and deep red to gray in color. They vary in consistency. Unlike nasal polyps of allergic origin, they are unilateral. Patients generally present with nasal obstruction, postnasal drip, and headaches. A few have epistaxis. These lesions occur mainly in men between 50 and 70 years of age. The reported incidence of malignant degeneration is about 2%. The incidence of associated malignancy in adjacent tissue is as high as 15%. Complete excision is the course of treatment for these lesions. Recurrence is common because excision is often incomplete. Laryngeal papillomas are the most common laryngeal tumors of childhood and may be found at any age. Juvenile type occurs predominantly in childhood and tends to involute at puberty. Etiology is viral. Multiple papillomas are the most common characteristic. They may involve the airway from the epiglottis to the bronchi. The vocal folds are usually involved. Hoarseness is an early sign, and obstruction is a later one. Treatment may include tracheotomy, but this should be avoided if possible because it predisposes to tracheal seeding of the papillomas. Laryngoscopic removal, often by the use of a carbon dioxide laser, is the mainstay of therapy. Interferon therapy has not proven to be as useful as early reports predicted. Cidofovir use has become common, and vaccination is now available. Other medical therapies are under investigation. Recurrence and spread are common. Adult nasal papillomas generally are single. As in the juvenile form, the papilloma tends to recur following excision. Recurrent lesions can undergo malignant transformation, particularly in patients exposed to radiation. Nasal polyps are rare before 5 years of age and occur more frequently in men. Nasal polyps are believed to be an allergic response, but this etiology has not been clearly established. Nasal polyps may be associated with asthma and an idiosyncratic reaction to aspirin. In children, the presence of nasal polyps should prompt a sweat test to rule out cystic fibrosis. Inflammatory polyps are almost always bilateral and may recur frequently. Involvement of the paranasal sinuses is common. Polyps should be excised if they obstruct the nasal airways of the sinus drainage pathway. Nodular proliferative fasciitis presents as a rapidly growing, discrete soft tissue mass. It may be a reactive, non-neoplastic response to injury, and it may occur at any time from childhood to age 70. The lesions may be mistaken for sarcoma. Fascia is the primary tissue involved. These lesions generally do not recur after excision. Proliferative myositis occurs in adults and appears to be post-traumatic in origin. Like nodular fasciitis, it can be confused with sarcoma. The lesion involves muscle diffusely. Occasionally, spontaneous regression occurs. Lesions do not recur after excision. Traumatic myositis ossificans are bony deposits in muscle due to trauma and generally presents as a painful mass in the muscle 1 to 4 weeks after a single severe trauma. When present in the head or neck, the masseter or sternocleidomastoid is generally involved. Radiography reveals feathery opacities or irregular radiodensities. This condition must be differentiated from myositis ossificans progressiva, which is a progressive systemic illness that begins early in life and results in the conversion of muscle tissue to bony tissue. Persistent painful masses are excised. Local recurrence is common. Desmoid tumors are benign, locally invasive, and encapsulated tumors. They arise from the muscle fascia and are often associated with prior trauma. These tumors are uncommon in the head and neck, but when found, usually arise from the sternocleidomastoid muscle. Complete surgical excision is the treatment of choice. Extracardiac rhabdomyomas have a predilection for the head and neck. They show a slight male predominance. Signs and symptoms depend on the site and size of the lesion. Rhabdomyomas are treated with complete surgical excision, if possible, followed by chemotherapy and radiation. Schwannomas are solitary encapsulated tumors attached to or surrounded by a nerve. They are primarily located centrifugally and are often painful and tender. They are not associated with von Recklinghausen's disease or with malignant change, in contrast to neurofibromas. Acoustic neuromas constitute a type of schwannoma. They arise from the 8th cranial nerve, usually start within the internal auditory canal, and can involve the cerebellopontine angle. Signs and symptoms indicating acoustic neuroma include hearing loss, tinnitus, imbalance, and vertigo. Asymmetric sensorineural hearing loss is common in patients with acoustic neuroma, and this should be ruled out. Testing includes audiogram, auditory brainstem response testing, and MRI with gadolinium enhancement of the brain and internal auditory canals. Early discovery is important because it results in earlier resection, with a consequent decrease in morbidity and mortality. Von Recklinghausen's neurofibromatosis is caused by a nerve growth factor gene on chromosome 17q11.2, an autosomal dominant inheritance factor. Usually, these lesions are located centripetally and are characteristically asymptomatic. These lesions are usually multiple and encapsulated. Neurites, axons, pass through the tumor. In 8% of patients, neurofibromas undergo malignant changes. Central neurofibromatosis, Nf2, is caused by an abnormality on chromosome 22111.21-13.1 and involves encoding of a suppressor protein called Shanamin. Inheritance is autosomal dominant, but almost 50% of cases are new mutations. Classically, these lesions are slow-growing bilateral acoustic neuromas or neurofibromas and may cause hearing loss or dizziness, leading to a diagnosis by age 20. The diagnosis may also be established by a unilateral eighth nerve mass and/or a relative with Nf2 or any two of the following: glioma, juvenile posterior subcapsular lenticular opacity, meningioma, or neurofibroma schwannoma. Café au lait spots, posterior lens cataracts, and cutaneous neurofibromas are uncommon. Lish nodules are not found. The Wishart type of this lesion presents as early onset of rapid growth and other fibromatous tumors in addition to eighth nerve masses. The Gardner type presents as a later onset, slow growth rate, and usually bilateral acoustic neuromas only. Traumatic neuromas are reactive hyperplasias due to a nerve's attempts at regeneration following injury. They are generally oval or oblong, gray, firm, and unencapsulated. Usual signs are persistent hyperesthesia and tenderness. Most neurogenous tumors of the head and neck can be excised safely without sacrificing nerves. If an important nerve must be cut, it should generally be re-anastomosed or a nerve graft should be interposed. Congenital epulis occurs on the gum pads of newborns in the region of the future incisors. The lesion can be quite large, does not recur after excision, and may spontaneously regress. The female-male ratio is 8:1. Non-epulous form of granular cell tumors occurs mainly in young adults, especially in people of African descent. Paragangliomas, chemodectomas, can occur in the head or neck and are discussed in the presentation on malignant lesions of the head and neck. Giant cell granuloma can occur in two forms. Central granulomas occur within the jaw. Peripheral granulomas occur on the gingival or alveolar mucosa and are 4 times more common. The mucosa is generally intact, but radiographs of the central lesion show radiolucent areas. Treatment of choice, excision, or curettage. Fibrous dysplasia of the jaw is noted early in life. It shows active growth in childhood and stabilization in adulthood. Enlargement of the bones is the most common sign and may be either minor or significant enough to cause obvious facial asymmetry. The maxilla is more commonly involved than the mandible. Radiographs may reveal sclerosis, lytic lesions, or unilocular lesions. Obvious deformity, pain, or interference with function suggests the need for surgery. Malignant transformation is possible but uncommon, and conservative resection appears to be the best treatment. Torus palatinus is a benign bony growth occurring at the midline of the palate, maxillary torus, or bilaterally lingual to the bicuspid, mandibular torus. Tori grow slowly and generally are not significant, except that they may interfere with the fitting of dentures. Osteomas are slow-growing benign tumors in the sinuses, jaws, or external ear canals. They may require excision if they produce a headache or an occlusion of drainage. Laryngocele is a dilatation of the laryngeal saccule, producing an air sac that communicates with the laryngeal ventricle. Anything that increases interlaryngeal pressure increases the size of the laryngocele, e.g., coughing, straining, playing a wind instrument. A laryngopyocele is an infected laryngocele. It can be fatal if it results in asphyxia from compression or if the purulent contents are aspirated into the tracheobronchial tree. Laryngoceles may be unilateral or bilateral. They may also be internal, within the larynx, external, presenting in the neck, or both, combined. An internal laryngocele causes bulging of the false vocal fold and aryepiglottic fold. It may cause hoarseness, breathlessness, and stridor on enlargement. An external laryngocele appears as a neck swelling at about the level of the hyoid bone and anterior to the sternocleidomastoid. It increases in size with coughing or the Valsalva maneuver. It is tympanic to percussion. As the laryngocele empties air into the larynx when the air pressure is reduced, a hissing may be heard. Radiographic studies should be instituted to determine the extent of these lesions. Plain films may show cystic spaces that contain air. Tomograms may help to demonstrate the continuity between the internal and external components. CT and MRI scans show these lesions well. Surgical excision is typical for symptomatic laryngoceles. Laryngopyoceles should be treated by incision, drainage, and subsequent excision, and institution of antibiotics is also prudent. Laryngeal webs may be congenital or may follow bilateral vocal fold trauma. When extensive, they present with stridor, weak phonation, and feeding problems in infants. Excision or division is now generally the preferred treatment, and placement of a stent or keel is often required. Vocal nodules are bilateral benign masses that usually occur at the junction of the anterior and middle thirds of the true vocal folds. They are usually associated with vocal abuse and are best treated by modifying the patient's speaking or singing technique through voice therapy. Surgery is rarely necessary and is generally performed only after failure of voice therapy. Vocal polyps are usually unilateral and often do not regress with speech therapy. Two important points in distinguishing the polyps from vocal nodules. Recommended therapy is careful excision with microscopic visualization and avoidance of injury to the underlying lamina propria. Laryngeal granulomas occur over the vocal processes of the arytenoid cartilages. They are generally the result of trauma, usually from an endotracheal tube, and are usually associated with reflux laryngitis. Voice abuse may also be a factor. Anti-reflux therapy is often helpful in the treatment of granulomas. They can regress as a result of treatment with anti-reflux medications and speech therapy. Persistent granulomas, following a period of voice and medical therapy, are best treated by excision. Botulinum toxin may be used in selected recurrent cases. Arytenoid dislocation generally is the result of endotracheal tube or external injury. Patients with a soft, breathy voice following extubation should be suspect. Prompt reduction is advisable, otherwise the arytenoid usually becomes fixed in the dislocated position. However, late reduction, after months and years, can also be successful and should be attempted when diagnosis and treatment has been delayed. Contact ulcers are mucosal disruptions usually located posteriorly on the vocal folds. They sometimes result from trauma, for example, intubation, occasionally from vocal abuse, and often from gastric reflux laryngitis or heavy coughing. Treatment with anti-reflux medications and behavioral modifications, such as elevation of the head of the bed, avoidance of caffeine, chocolate, late-night snacks, and fried or fatty foods, and voice therapy, will usually result in prompt resolution of the ulcers. Antibiotics may be helpful as well. Common head and neck infections, for example, otitis media, mastoiditis, sinusitis, are now controlled with antibiotics, which must be given at high doses and over long periods of time for these sequestered spaces. Patients documented as having recurrent adenotonsillitis improve after tonsillectomy and adenoidectomy. A history of 5 or 6 episodes annually requiring antibiotics is a relative indication in adults. In children ages 1 to 18, current guidelines suggest avoiding tonsillectomy unless children have had more than 6 episodes of tonsillitis in the past year, more than 4 episodes per year in the past 2 years, or more than 2 episodes per year in the last 3 years. Exceptions are individualized and include problems such as antibiotic allergy or intolerance, periodic fever, aphthostomatitis, pharyngitis and adenitis, peritonsillar abscess, and sleep-disordered breathing. Tonsillectomy is often suggested after treatment for peritonsillar abscess in patients with a history of previous tonsillitis. Patients documented with recurrent adenotonsillitis are improved after tonsillectomy with adenoidectomy. A history of 5 or 6 episodes requiring antibiotics annually is a relative indication. Tonsillectomy is often suggested after treatment for peritonsillar abscess in patients with a history of previous tonsillitis. A typical Mycobacteria infection presents as an inflamed mass or draining sinus in the head and neck. It is most common in children and adolescents. It is commonly associated with the parotid and submandibular glands, but it is not isolated to these sites. Fixation of overlying skin and sinus formation are common. Biopsy can lead to a chronically draining sinus tract. Pulmonary involvement is rare. Treatment by surgical excision or curettage and drainage are common. Antimycobacterial drug therapy is not indicated for these types of lesions. Salivary glands are associated with many lesions of the head and neck. They are important, but outside the scope of this presentation.